So today we are going to learn about hyperparathyroidism. What is parathyroidism or hyperparathyroidism for that case? Hyperparathyroidism is an increase in parathyroid hormone, that is PTH levels in blood. This occurs either from a disorder within the parathyroid glands, primarily hyperparathyroidism, or a disorder outside the parathyroid glands, secondary hyperparathyroidism, resulting in too much PTH, the parathyroid hormone. Most people with primary disease have no symptoms at the time of diagnosis. In those with symptoms, the most common is kidney stones, with other potential symptoms including weakness, depression, bone pains, confusion, and increased urination. Both types increase the risk of bone or weak bones. So the types of hyperparathyroidism can be primary or secondary. The primary one, we've said, it is the 80% of the cases, and it is due to a single benign tumor known as a parathyroid adenoma, with most of the rest of the cases due to multiple benign tumors. Rarely, it may be due to parathyroid cancer. Secondary parathyroidism, parathyroid adenoma, that is one of the causes. Multiple benign tumors, parathyroid cancer. Typically, it occurs due to vitamin D deficiency, chronic kidney disease, or other causes of low blood calcium. So radiation exposure increases the risk of primary hyperparathyroidism. A number of genetic conditions, including multiple endocrine neoplasia syndromes, also increase the risk. If you cannot understand anything up to there, there's no hope for understanding anything. Primary hyperparathyroidism. In primary hyperparathyroidism, about 75% of people have no symptoms. The problem is often picked up during blood works for other reasons via a raised calcium level. Many other people only have non-specific symptoms. So symptoms directly due to hypercalcemia are very rare for that case, being common in patients with malignant hypercalcemia. A history of acquired raquet nails, that is brachionychia, may be indicative of a bone resorption. Parathyroid adenomas are very rarely detectable on clinical examination. Surgical removal of a parathyroid tumor eliminates the symptoms in most patients. Continuing, if present, most manifestations of hypocalcemia include weakness and fatigue, depression, bone pain, muscle soreness, myalgias, decreased appetite, feeling of nausea and vomiting, constipation, polyuria, polydipsia, cognitive impairment, kidney stones, osteopenia, osteoporosis. Parathyroid adenomas are rarely detectable on clinical examination. Surgical removal of a parathyroid tumor eliminates the symptoms in most patients. Secondary hyperparathyroidism, caused by vitamin D deficiency, chronic kidney disease, low blood calcium. Lack of vitamin D leads to reduced calcium absorption by the intestine, leading to hypocalcemia and increased parathyroid hormone secretion. This increases the bone resorption. In chronic kidney failure, the problem is more specifically failure to convert vitamin D to its active form in the kidney. The bone disease is secondary. Okay, let me give you an example. The bone disease in secondary hyperparathyroidism caused by kidney failure is termed as renal osteodystrophy. So it occurs secondary to the other condition. Clinical problems are due to bone resorption and manifest as bone syndromes such as rickets, osteomalacia, and renal osteodystrophy. So by the end of the lesson, we will be understanding that well. Pathophysiology. Normal parathyroid glands measure the ionized calcium, that is Ca2 plus concentration in blood, and secrete parathyroid hormone accordingly. When the ionized calcium rises above normal, the secretion of PTH, that is the parathyroid hormone, is decreased. Whereas calcium levels fall, parathyroid hormone is increased. So from that case, we can already figure out that when the ionized calcium rises above the normal, our parathyroid hormone will decrease. Whereas the opposite is also true. When it falls, the parathyroid hormone is increased. So secondary hyperparathyroidism occurs if the calcium level is abnormally low. The normal glands respond by secreting parathyroid hormone at a persistently high rate. This typically occurs when the 1,2,5 dihydroxy vitamin D3 levels in the blood are low and there's hypocalcemia. A lack of 1,25 dihydroxy vitamin D3 can result from a deficient dietary intake of vitamin D or from a lack of exposure of the skin to sunlight, so the body cannot make its own vitamin D from cholesterol. The resulting hypovitaminosis D is usually due to a partial combination of both factors. Vitamin D3, in brackets cholecalciferol, is converted to 2,5-hydroxy vitamin D or calcidiol by the liver, from where it is transported via the circulation to the kidney, where it is converted into an active hormone 1,2,5-hydroxy vitamin D3. Thus, a third cause of secondary hyperparathyroidism is chronic kidney disease. Here, the ability to manufacture 1,2,5-dihydroxy vitamin D3 is compromised, resulting in hypocalcemia. So how can we diagnose this condition? Of course, during routine tests, we will notice high blood calcium, high parathyroid hormone levels, the gold standard of diagnosis. Then classical X-ray appearance of hyperparathyroidism. The treatment, of course, one is monitoring the patient. We have surgery, IV normal saline, so it helps to reduce the amount of calcium in blood, calcimetrics, and cinacalcet, a medication used to reduce PTH levels. Surgery is also a way of treatment. People with primary hyperparathyroidism who are symptomatic from the disease benefit from the parathyroidectomy. That is a surgery to remove the parathyroid tumor, parathyroid adenoma. Indications of surgery are as follows. Symptomatic hyperparathyroidism, asymptomatic hyperparathyroidism with any of the following: 24 hours urinary calcium less than 400 mg, serum calcium less than 1 gram per deciliter above the upper limit of normal, creatinine clearance less than 30% below the normal for patients, bone density less than 2.5 standard deviation below peak, that is t-score of less than 2.5, people of age less than 50. So asymptomatic hyperparathyroidism with any of the following 24-hour. So this is basically what we've just covered in a more clearer slide. In people with secondary hyperparathyroidism with high PTH, that is parathyroid hormone levels, are an appropriate response to low calcium, and treatment must be directed at the underlying cause. This is usually, the underlying cause can be vitamin D deficiency, CKD, that is chronic kidney failure. If this is unsuccessful, PTH levels should be if this is successful, the PTH levels should naturally turn to normal unless PTH secretion has become autonomous, that is tertiary parathyroidism. So calcimetrics such as cinacalcet is a potential therapy for people with severe hypercalcemia or primary hyperparathyroidism who are able to undergo parathyroidectomy, who are unable to undergo parathyroidectomy, sorry for that, and for secondary hyperparathyroidism on dialysis. In the treatment of secondary parathyroidism due to chronic failure on dialysis, calcimetrics do not appear to affect the risk of early death. They do decrease the need for a parathyroidectomy, but cause more issues with low blood calcium and vomiting. So we've reached the end of our document and our lesson today, and now you understand more. Thanks and for the contributors to the document. Thank you.